Hi, everyone. I think that might be one of the first times I've taken a mask off indoors, so it feels weird. I'm so excited to be here and share with you this talk. It'll be a little different than what we've heard thus far, but I would like to take you through some of my work looking at LIFECOURSE health equity. The outline of this talk will be to begin with talking about some LIFECOURSE exposures, specifically around the psychosocial environment, but then we will bridge those mechanisms to those that are more broad. We'll talk about how these can lead to intergenerational disease disparities. I'll also be using cardiovascular health and diabetes as some examples in the clinical practice. But we'll also discuss how LIFECOURSE exposures and adversity is not necessarily destiny. There's a health equity approach we can take in policy work and also our research to try to build on solutions. So discussing LIFECOURSE exposures, I'd actually like you to just take a minute, sit back, and try to use your imagination with me briefly. Imagine this child who's just ended a conversation online, communicating with his mother, who's engaged currently in mental health and substance use disorder treatment, but needs to be away from the home in order to do it. And this teen who's just locked herself in her room because she's fearful of the violent fighting happening outside of it between her parents. Across the LIFECOURSE at a population level, children who are exposed to adversities have increased risk for biological dysregulation across multiple systems, increased risk of smoking, obesity, and sedentary behaviors, and a 4 to 12-fold increased risk of substance use and mental health disorders across the LIFECOURSE. There's also a decreased, quote, life potential, as the literature specifically quoted, in terms of risks of things like incarceration, and broadly speaking, influences across the leading causes of death in the United States, and even premature death, all because of exposure to adversity in childhood. Over 60% of the population in the United States surveyed has been exposed to at least one adverse childhood experience, and they lay the foundation for increased morbidity and mortality across the LIFECOURSE. These exposures, such as abuse and also challenges in the household, first and foremost must be viewed through a structural lens, not individualistic. For example, they have population-wide impacts. The CDC projects that their mitigation can actually prevent up to 1.9 million cases of heart disease. However, not only are the exposures, but the outcomes are overlaid by structural inequities that lead to racial and ethnic disparities. One small study I did also exemplifies what we've heard this morning, that timing matters for exposure. For one cohort of women with chronic pain disorder, we found that abuse in childhood was correlated with lower pain thresholds, as you can view in the graph there from left to right, with exposure to abuse portending to lower pain tolerance. However, exposure in adulthood was not. So how do these things manifest in biological systems and in population health? Let's talk about the definition of toxic stress. This is something known very well to pediatricians, but is becoming more cited in the literature. Now, there are normal and healthy stressors, for example, public speaking, those that we use to gain personal growth. And then there are stressors that many of us, if not all of us, have experienced challenges throughout life, experiencing challenges with mental health or family loss. And those can still be overcome with significant support, coping mechanisms, and adequate resources. And then there's toxic stress. Toxic stress becomes biologically imprinted, affects our own physiology. And that happens either when the stressors are of intense exposure or over a longer period of duration, or if the individual or population has inadequate access to coping or buffering mechanisms. This manifests as multi-system impacts on stress physiology. It can happen through neurologic, endocrine, immune pathways, but ultimately resulting in disparities in health outcomes. Not only is this related to the toxic stress that may occur early in childhood through these adverse childhood experiences I mentioned, but of course traumatic experiences like war, famine, witnessing murder, which unfortunately in the United States is now becoming a reality for many of our children, and expanded ACEs, which is a specific term used in literature, but refers to and includes exposure to discrimination and racism. So let's dive into what we mean by the overlap between racism, discrimination, and toxic stress. Before we can discuss the impacts of racism on the toxic stress physiology, we must understand a common semantic. Racism happens at many levels: the interpersonal level, the institutional level, and the structural level, amid many in between and all around. Collectively, this can input burden on certain populations, perhaps individuals, leading to health disparities, again, across multiple systems. I'm going to make a case for certain systems of biology, but then give you an important message on the next slide about them, so please hang in there. The neurobiological processes can be through many different regions of the brain, including those that process concentration, for example, or executive function, the stress response through the hypothalamic pituitary adrenal or HPA axis, and can affect circadian rhythms, abilities to concentrate. And that can have also neuroendocrine impacts, where these neurochemicals have impacts throughout the body, potentially cardiometabolic influences. So I'll actually show you some evidence of how stress physiology can overlay with exposure to, to physiological processes such as insulin resistance. And also their immune processes, increased levels of inflammation or the inability to repair things like endothelium, which lead to cardiovascular disease or other conditions. And certainly these systems all interact. I couldn't even put enough arrows on this slide, and have embedded processes like epigenetics. Not the only, we heard there are many other omics, but one example herein, which I will also provide through the epigenetic underpinnings of the stress axis, for example. But racism harms health much more broadly than thinking about individual physiology. It can happen through our environments. You all are the experts of this even more than I, such as through endocrine disrupting chemicals and policies that lay the foundation for inequities like residential segregation. There can also be decreased access to resources across different populations that can buffer adversities like the ACEs I explained before, but many others experienced in the life course. Therefore, this diagram is not complete without mentioning that this is a compilation of exposure to chronic stress, neighborhood and environmental inequities, and access to buffering resources. This compilation of toxic stress physiology is also being quoted in the literature and known as allostatic load, the burden on all physiologic or multiple physiological systems. And some exposure examples besides ACEs, as we mentioned, could be chronic illness. And if we're talking here about individual stress, it might be more interpersonal or experienced racism or discrimination. And I'm going to talk today about an example chemical, cortisol, the main chemical we might think of in the stress axis. But certainly, please know that what I have discussed is not limited to cortisol or even the stress response system, but rather serves an example of how we can understand the integration of social sciences with biology. These pathways, such as the stress response, can become embedded and portend risk to disparities in mental and physical illness. We all know very well the exposome also is foundational in impacting our biology, and this may come in many ways in the environment that certainly intersects with experiences of inequities, green space, housing, chemical exposures, and then the systematic and structural layers of racism and discrimination. This can also impact physiology, embedding disparities across the life course. So importantly, there is a crucial intersection that we must not study either in isolation of. The stress and allostatic physiology, for example, cannot be separated from environmental exposures, and we must know that at their intersection lies experiences of adversity, racism, and discrimination. This is a crucial point if you take away nothing else from my talk. Though I will be talking a lot about biology, race is not a biological construct. Rather, biological differences by race and ethnicity are due to the physiological manifestations and mechanisms impacted by adversity, racism, and discrimination intergenerationally. Such entrenched systematic and intergenerational problems observed as disparate health outcomes must put the onus on structures and systems for solutions, not on individuals. Therefore, we must take a socio-ecological view of health disparities before we can pivot to solutions. Here you can see the blue circle identifies individual factors that might lend risk to life-course disease, but you can also see that there are inequities in clinical practice and policy and structural systems levels, especially in the environment, that influence disease risk, here exemplified by the increased risk for cardiovascular disease across the life course. This intergenerational exposure to racism, discrimination, and adversity is similar to that of ACEs in childhood, potentially in physiology, but is very specific in terms of how it's become a historical part of our society. We can go back to slavery and post-Civil War times, but these exposures have remained in our society in terms of inequities. They've trickled down into disparities that we see in terms of even closures of medical schools that were historically Black institutions. The pointing out of individuals that tried to test theories that supported a discriminatory view of biology, and also social constructs and the way that healthcare systems approach equal or unequal access to care, for example. All of these can trickle down in many ways, more than I can identify today, embedding a sense of stress, imbalanced physiology that importantly may not even be measured in an individual because it is so intergenerationally entwined. One study we conducted was looking at how elevated cortisol, stress hormone, was associated with diabetes in the Jackson Heart Study. This is a cohort of individuals who primarily identify as Black or African American and involves a longitudinal follow-up in terms of medical history and laboratory evaluation. We found that those in the highest quartile of morning cortisol, which for those who are less familiar, cortisol should be lower in the morning when you first wake up, they had an over twofold risk of prevalent diabetes in this study. But importantly, like we've been talking about today, what matters is longitudinal analyses. So we also went on to study in a diverse cohort how the cortisol curve over the timing of the day was related to the development of incident diabetes over time. Interestingly, we found an association of a flattened cortisol curve, so a less responsive cortisol response, in individuals who identified as white, and found no association in individuals who identified as Black. But we might be able to interpret this by understanding the constructs of adversity across the life course. Looking at this same diverse cohort, this is, by the way, the Cardia study cohort, epidemiological study nationally, we found that early life stress exposures, like ACEs, as I described earlier, also impacted the curve in a similar fashion to that association with diabetes. This was irrespective of race, and it's possible that intergenerational or early exposures are really what's laying the foundation for some of the biological differences that we see across the life course. So just to summarize and pivot, I would like to say childhood adversity is clearly associated with chronic disease in adulthood. The cortisol and stress pathway is associated with diabetes, and both child adversity and racism are associated with disparate cardiovascular disease outcomes. Research by individuals I know are at Sinai and others, maybe some in this room, has demonstrated there are epigenetic modifications such as FKBP5, which lies within the stress axis, that could be related to intergenerational adversity. And so we also then went on to ask the question, is FKBP5 epigenetic modification associated with cardiovascular risk in adulthood? Trying again to get at those kind of longitudinal assessments of impacts, even in cross-sectional studies. So just for quick background, this is probably not news to most, but epigenetics can mean many things. Here we're talking about a gene-specific modification solely at one site, the FKBP5 gene, and we're talking about methylation at that site, which in the literature traditionally is related to inhibition of the gene, that particular gene expression. Here we're not testing functionality, but rather looking at simply modification. The hypothesis driven by prior literature is that the stress axis could become overburdened, leading to hypercortisolism, even if that's in isolation, meaning not necessarily hypercortisolism over years, but for an extended period of time at least, to bind to the glucocorticoid or cortisol receptor, travel to the nucleus, and over time lead to methylation of this FKBP5 gene, which others have found in multiple cell types of the body to be a potential biomarker of chronic stress. In a cohort of individuals who are 61% identifying as Black, we found that there was an association between increased methylation levels at multiple different sites of the FKBP5 gene and increased risk factors for cardiovascular disease, such as elevated A1C, LDL cholesterol, and adiposity. Interestingly, we also found that there was a correlation with one of those most prevalent methylated sites with cardiovascular procedures, indicating that there may also be some clinical correlates, at least hypothesis generating for future work. And we found that physical activity, speaking to cardiovascular health as in our prior talk, was inversely correlated with the percent methylation, adjusting for waist circumference. So putting this all together, we can see that there's at least a hypothesis being generated here for the idea that early exposures can influence life course risk. While limited and not yet assessing the epigenetic change over time, our study does generate a hypothesis of how chronic or intergenerational adversity may be associated with disparities across the life course, but more research is needed, and those who are experts in potentially epigenetic clocks and other multifaceted and longitudinal methods could help us account for this. But it is really important to remember that the associations that we observe between early adversity remain across demographic characteristics, and so it must continue to be studied. This actually led us to continue the study in the cardia cohort to look at two different pathways for early childhood exposure. And this may pertain to other types of environmental risk if you extrapolate this conceptual framework. Taking the early adversity environment and looking at stress physiology, we actually found that ACEs, or adversity in childhood, was associated with altered HPA axis function 20 years later in the life course. This is known by other literature to be associated with increased cardiometabolic risk. And in that same cohort, we found that early adversity was also associated with poor lifestyle or inability to attain that cardiovascular health ideal. This also laying risk, therefore, for morbidity and mortality. But very importantly, the literature and our work demonstrates that both of these processes can be influenced by having social support and even negating these outcomes. Therefore, adversity is not destiny. This is actually a quote that I've used from our president of the American Academy of Pediatrics. Very specifically talking about toxic stress, I've worked with the first Surgeon General of California, Dr. Nadine Burke-Harris, who popularized the concept of ACEs. And together with her report in a recent publication, we've discussed that there are ways to mitigate this response over time, and there are many of the areas you all are likely researching, including environmental access to nature, but also stress reduction techniques, physical activity, balanced nutrition, quality sleep, mental health care, and importantly, if not the most important, supportive relationships. In fact, our study did not end with what I shared with you earlier, but we found that positive childhood experiences, measured in this case by reported caregiver warmth, was associated with higher levels of cardiovascular health across 20 years of follow-up. Specifically, each increment of caregiver warmth gave a 12% higher odds of attaining cardiovascular health across the life course. While experiences of individual adversity, it's not individualistic destiny, systematic problems must have systematic solutions. Therefore, we must also take a socio-ecological approach to health equity. Again, the multi-layers of solutions which we can each individually research, but also need to collectively research. This may involve things like addressing community engagement in our studies. This may also involve looking at work with policies that aren't necessarily isolated to environmental exposures, but consider psychosocial disparities. And this may also come through our own clinical practice and policy. For those who share clinical practice like myself, we know that there's an opportunity every time we're in an exam room to discuss the multi-layered exposures of inequities in our society. And this is an example of how to do that, becoming aware and knowledgeable, and importantly, collaborating, knowing our own limitations and implicit biases, and bringing in stress mitigation, or specifically toxic stress mitigation methods whenever possible. And importantly, we must advocate. This is an example where I brought some of this work to the City Council of Baltimore, and this policy actually passed to inform the embedding of a community advisory council to discuss how toxic stress and adversity can be combated in the local community. SAMHSA, or the Substance Abuse and Mental Health Services Administration, has a framework we can all build off of to do such work. And again, in work with Nadine Burke-Harris, the first Surgeon General of California, she began the ACEs Aware initiative, of which I was grateful to be a part of, which demonstrates that we can take science, even though it may take time, as we heard this morning, and try to directly translate into policy. This is a current initiative at the University of California. And we can learn from our colleagues and pivot into what we're probably all most interested in immediately, which is research. There is a nice commentary about bridging disciplines across biology and social cases, for example. And in this quote, we can see that the authors are pretty intense on their demonstration of the need for this collaboration, citing that some social scientists may cringe at seemingly reductionist efforts to reduce social problems to biological ones, and some biologic scientists may be unable to move beyond the controlled environment of disease models, but we must unite in the face of a common enemy, which here I'll label as disparities and inequities. The research implications are that community-based studies must consider the exposome, the totality of exposures we all know and are talking about today, to better address structural racism, which I know was raised earlier, and could impact stress physiology, for example. I just will briefly take you through a study that I encourage you, not only as a shameless pitch to read, but because I do think it sort of exemplifies how we're trying to do some integrated work. This was a model where we assessed in a community that identified predominantly as Black and of low income, a neighborhood study. We actually engaged community as part of our study team to collect data on the environment, the lived experiences of individuals, and to share biological samples, of course, with their not only consent, but input on the methodology. We did this by using cortisol, and because cortisol is time dependent, we had to be very sensitive about those collections. Usually to measure a diurnal cortisol variation across the day, 4 time points are required, but you can imagine this being very resource intensive for a community engaged project. So again, our community participants actually helped in this study by becoming field workers and partnering with the investigation team, and the trust that was built was actually cited by participants as a means for their feeling invested in the research. Those field workers went into the homes and not only collected traditional survey metrics, geocoded data, but also provided close instruction about the biological sample collection. And here you can see an example of how this was done, and it's in a supplement in our paper if of interest to others. And with that trust and that mechanism, we were able to obtain nearly 100% of the expected cortisol samples for this data. And when you look at the cortisol curve, speaking of how we were going to analyze this data, Those familiar with cortisol analyses know that many of the common metrics are time dependent based on slope. For example, I talked about morning cortisol being low. That was an isolated time point, but ideally it should rise steeply, and that's called the cortisol awakening response. We hypothesized, however, that the cortisol dynamic range, taking 2 points, one in the morning and one in the evening, would give us some more measure of variability across the day, with being not entirely independent of time, of course, but a little bit less so than a slope. And we actually found that this was feasible and of decent quality. The cortisol awakening response relying on slope was of low quality, in fact, often downsloping, which is near physiologically impossible to my knowledge, whereas the cortisol dynamic range was collected within 30 to 45 minutes of the expected window of time. And what we saw was that cortisol dynamic range, larger range, more adaptable stress response was actually associated with lower age and greater mental health, as expected, not associated with the time-dependent measures. So community-based research in a predominantly Black and low-income community was feasible using cortisol dynamic range, and our recommendations, therefore, are not only to engage community, but to think about directions and support when conducting research, and for cortisol specifically being inclusive of time. I just want to end on a few very broader examples of work that's looking at to use the socio-ecological model, inclusive of, for example, home blood pressure monitoring. We heard about other digital metrics involving nurse case managers and community health workers, and importantly, always having at least a community advisory board, and being very intentional about involving those participants not only in the work, but as co-authors, which we did on our paper. And lastly, I can't go into the depths of health equity research, but importantly, identifying semantics of how individuals or populations identify as when we use race or ethnicity. Disaggregating data, an example is we know that individuals of Puerto Rican ethnicity or Mexican identity, for example, have increased disparities where those of Cuban origin may have less. And race is not genetic or biological, so when it's used, it must be used with intention as a surrogate for other inequities, specifically racism, and that should be cited in our work. There are tools to support this through the NIH. The Social Determinants FENEX Toolkit is one example, and clinically, in both clinical practice and study, the national class standards can help us make sure equity is embedded in our own practices. So in summary, the big picture is LifeCourse research must integrate both biomarker and health services methodology and shape policy and practice with the embedding of communities in order to mitigate LifeCourse disease outcomes. That's the target. And in summary, again, early adversity is a risk factor for chronic disease, as is racism and discrimination. The stress pathway may be one of many potentials to explore. Adversity is modifiable, importantly, and is not an onus on an individual, but is on all of us to mitigate through health equity with systemic solutions. So with that, thank you so much, and I look forward to questions here, or please reach out to me or tweet. Thanks a lot.